Hello, everyone, and a warm welcome to today's edition of Patcast. Today is November 15th, 2024, and I'm Rifat Manan in California. We are continuing with our Dermpath lecture series, and this is going to be the third lecture in the series. And today we are very delighted to welcome Dr. Jacqueline Junkins Hopkins, and she is a very renowned dermatologist and dermatopathologist. So currently she works at Geisinger Medical Center in Pennsylvania as a staff dermatologist and dermatopathologist. And today's lecture, she is going to talk about a very important topic, that is vacuolar and lichenoid interface dermatitis. And without further ado, I would love to welcome Dr. Hopkins to the talk today. And thank you for joining us. Over to you, Dr. Hopkins.
Hi, good morning or good afternoon, wherever you are. Thank you for tuning in to the lecture, either now or in the future, whenever you happen to be listening to this. I'm honored and excited to be able to be a part of this lecture series. I think it's a really great thing that Rifat does, and thank you for having me. So we're going to be talking about vacuolar and lichenoid interface dermatitis. Hang on, I'm going to take off my video now. I'll see you guys a little bit later. All right, I have no conflicts of interest. I think I have to move that in the corner there. I practice at Geisinger Medical Center, which is in the middle of Pennsylvania, not too far from New York and Philadelphia. But we have a great group of dermatopathologists and dermatologists here, so we have a lot of fun. Let's see, how do I make this go? So in general, there are a lot of terms used and sort of interchangeably and a little bit indiscriminately to refer to this concept of lichenoid or vacuolar interface dermatitis. People refer to it as interface dermatitis, vacuolar interface, lichenoid interface, lichenoid tissue reaction. And sort of whatever term you use, the common denominator in this sort of whole group of disorders is the epidermal and dermal interface is disrupted. There's basal cell damage, and then you have degeneration of the basal layer and this characteristic interface alteration. So overall, the common denominator is an interface dermatitis, and this could be vacuolar, where it's not that inflammatory, or lichenoid. So the vacuolar interface dermatitis is paucicellular. Sometimes I refer to it as a naked interface reaction. Scant lymphocytes are seen. They sort of approximate and disrupt the basal keratinocytes, resulting in vacuolar change and liquefactive degeneration of the basal keratinocytes. Lichenoid interface dermatitis is usually applied to situations in which there is a band-like inflammatory infiltrate that obscures and disrupts the basal layer. And a lot of times this is associated with disc keratosis. Both can have disc keratosis, but sometimes you see that a little bit more in the lichenoid, quote-unquote, lichenoid dermatitis. And usually you do see a combination of these. So there are different components. There's the components of an interface dermatitis. The lymphocytes disrupt the basal layer. And so there are, as I mentioned, lymphocytes there that may be band-like or sparse. There's the interface alteration, which I mentioned. People refer to the vacuolar alteration as liquefaction, hydropic change, balloon degeneration. A lot of disc keratosis can be seen, and eventually, again, the basal cells sort of degenerate. And sometimes this, or often this presents as sort of a ragged or smudgy appearance of the basal layer and that interface. And then the other component is keratinocyte damage, which sometimes is more prominent than other times. People refer to this as necrotic keratinocytes, dyskeratotic, apoptotic keratinocytes, savate bodies. And when they're dropped down into the dermis, where you just have the pink keratin blobs, that's referred to as colloid bodies. And then you have squamatization of the basal layer. So the basal layer, instead of having that nice cuboidal sort of basaloid appearance, appears pink and similar to the spinous keratinocytes, and they sort of go directly on the dermis. We'll go through some examples of this. So this is sort of a list that's my list, but it also overlaps with other people's lists of what's considered lichenoid interface. So the classic one is lichen planus. There are different presentations of that. Lichenoid drug eruption, lichenoid keratosis is a very common one, also referred to as benign lichenoid keratosis or BLK, or lichen planus-like keratosis or LPLK. Pityriasis, lichenoides, both chronica and acute, the pleva or pleva and PLC, lichen striatus, lichenoid pigmented purpura, lichenoid mycosis fungoides, syphilis. Syphilis is on everybody's list. Annular lichenoid dermatitis of youth, or it's also just called annular lichenoid dermatitis. Lupus, erythematosus, lichen sclerosis, lichenitis, lichenoid regression of melanoma, halo nevus, fixed drug eruptions, and sometimes porokeratosis can present with sort of a band-like interface reaction. And then the vacuolar interface reaction, or the sort of naked interface dermatitis, the classic example is connective tissue disease, which includes lupus erythematosus, dermatomyositis, and then a combination of the two, graft versus host disease, erythema multiforme, and Stevens-Johnson syndrome, along with toxic epidermal necrolysis. All those have a lot of overlap, as does fixed drug eruption. Pityriasis lichenoides can also present with just sort of minimal lymphocytes at the junction, drug eruptions, subacute radiation dermatitis, lichen sclerosis also can have a naked interface dermatitis, poikiloderma, vitiligo. Sometimes you can have what's referred to as late lichenoid regression or late lichenoid tissue reaction that you can see in various sort of later stage lichenoid dermatoses, including lichenoid keratosis. And lichen planus pigmentosus or erythema chronicum perstans is another sort of classic example of a naked interface dermatitis. And so there's a lot of overlap with these. Lichen planus, lichen lupus erythematosus, lichenoid keratosis, and pityriasis lichenoides all have their each distinct presentation clinically and histologically, even though they all sort of still overlap with that interface reaction. So classically, lichen planus is going to have this complete disruption and alteration of the basal layer to the point that you have my arrow. You don't even have the roundness of the reedy anymore. It's just jagged and pointed. Classically has some hypergranulosis that's somewhat wedge-shaped, hyperorthokeratosis with a dense band-like infiltrate. In contrast, pityriasis lichenoides has an interface reaction that's a little more subtle. It doesn't wipe away the reedy like lichen planus does, also associated with scale crust, hemorrhage, and lymphocytes around the vessels as well. Lupus erythematosus often will result in sort of wiping out of the reedy with interface change, a lot of pigment dropout, and then some thickening of the basement membrane zone, as you can see here. And then lichenoid keratosis really can have a combination of findings. This is sort of a classic presentation where you have a part of a lentigo at the edge and then a lichenoid tissue reaction that disrupts the basal layer. So this lichenoid keratosis can really have a lot of different ways it presents under the microscope, but it has a sort of a clinical presentation. And it's not really a keratosis, it's just a host response to the solar lentigo. They also have different ways they can present in the dermis. Lichen planus tends to be very band-like and restricted to sort of the area underneath the epidermis, whereas pityriasis lichenoides, in addition to this interface reaction that, again, does not wipe out the reedy, usually just sort of obscures the junction, and it tends to involve the vascular plexus. So you'll have this sort of wedge shape, especially when you draw a line like this, right? But the involvement of the superficial vascular plexus, postcapillary venules, and then also the other smaller vessels as they, start at the bottom of the dermis. And then lupus tends to be, classically more bulky around the inner nexal structures, so it won't be quite so wedge-shaped, even though it's around the vessels. It'll be sort of heavy in certain areas that happen to correspond to eccrine coils. And so as I'm going through this lecture, you're going to get repeats, and I'm sort of going through the approach, in terms of how you evaluate the type of interface reaction, as opposed to just an encyclopedic, running through all the entities, but you'll get some repeats here and there. So again, the architecture of the infiltrate, predominantly band-like, lichen planus, pigmented purpura, MF, and MF is on this list, but MF is rarely a lichenoid tissue reaction or interface dermatitis, but often will have a band-like infiltrate. So this is going to be in the differential. Halo nevus, lichenoid keratosis. Well, look at that. I put MF twice. Sorry about that. Just to emphasize my point. Lupus erythematosus, fixed drug, lichen striatus, lichenoid keratosis can have usually a little bit of both, and these also will tend to be more involving the vascular plexus. And then you can have both solidly band-like and prominently perivascular or periadnexal in some of these other conditions, and we'll go through each of these. So the diagnostic approach to interface dermatitis is to really assess all these things I've been showing you. So the density of the infiltrate, architecture, pattern of the interface alteration, how is the epidermis altered? Is it just lymphocytes or the eosinophils? What kind of dermal changes do you have? There are a few other things we look for. And most importantly, you have to have the clinical correlation a lot of times to have your ultimate diagnosis. So again, for the density of the infiltrate, we already went through this. You decide if it's sort of paucicellular or solidly band-like. How is the infiltrate in the dermis? Is it involving the vascular plexus and the deeper dermis? Is it periadnexal? Is it mostly interstitial? The pattern of the interface alteration, is it just sort of a mild vacuolar alteration? And again, I'm going to give you examples of this. Or is there a lot of disc keratosis or cytologic damage? Is the disc keratosis full thickness? Is there complete necrosis of the epidermis? Is there what we call satellite necrosis, where you have lymphocytes approximating the disc keratotic keratinocytes? So these are different things that we look at. Within the epidermal changes, again, we sort of see how the epidermis has evolved. Is it atrophic? Is it hyperplastic? Is there sawtooth 3D alteration? Is the stratum corneum basket weave? That tells us it's been a little bit more of an acute process. Is there scale crust? Is there hypergranulosis? Is the basement membrane thickened? You look at the infiltrate. Are the lymphocytes that mix with other inflammatory cells like eosinophils, which would put you more in a drug reaction usually? We know plasma cells usually put us in the category of syphilis. Sometimes you can have a granulomatous component. Sometimes you can have more neutrophils. And sometimes you can have atypia, and especially if it's mycosis fungoides. And then work our way down to the dermis. If there's Sometimes you'll only have melanophages, and that's your clue that there has been an interface reaction. Sometimes there's prominent sclerosis. You can see that in mycosis fungoides and in lichen sclerosis. Mucin obviously is something we see in lupus erythematosus, red blood cell extravasation in pigmented purpura. Sometimes you can have some vasculitis, and then we look for a few other things. So, and then of course, the clinical and pathologic presentation is what you're going to ultimately use to come up with your final diagnosis. And so clinically, it's, we all sort of, if you're listening to this, you probably are involved in some way with dermatopathology, and you know how important it is to have clinical input, the age of the patient, are they on drugs, do they have other conditions like arthritis and fevers? Is it a recurrent process? How has it been treated? Sometimes, for example, mycosis fungoides will be treated and you won't have a lot of the epidermotropism. Obviously, what do the lesions look like? Is it solitary or is it widespread? If it's solitary, it might be a lichenoid keratosis, but if it's widespread, it could be a host of other conditions. Is it photodistributed, like you might see in connective tissue disease? It's always good to review prior biopsies because sometimes a biopsy is taken of a lesion in a different stage of evolution, and another biopsy might give you more insight to the diagnosis. Sometimes stains are going to be important. Again, mycosis fungoides can help you if you think it might be an atypical process. CD123 for plasmacytoid dendritic cells can help support a diagnosis of lupus. And if you think that there might be some regressive lichenoid tissue reaction, then melanocyte markers will also help you. So let's just starting with the density of the infiltrate. Let's start with the lichenoid or band-like interface. So lichen planus is the prototype. My assumption is that it was named after the lichens that you see on the tree, where you have these little flat top lesions growing along on the skin. So it's classically this sort of very itchy, flat topped violaceous or pink papule. In patients with darker skin, obviously the pinkness will be a different color, sort of a violaceous darker color. And very, very itchy. A lot of times it will be linear. We've referred to that as it has Kebnerized. And so to me, the lichen part refers to clinically these flat top papules, but then now lichenoid has now referred to sort of the band-like histopathologic change that you can see with lichen planus. So it gets all sort of confusing, but this is how I always thought of the lichen part of this name. So you put the two together. With lichen planus, a lot of times, really, this is sort of all you need, and we can say it looks like lichen planus. So you just confirm it with the clinical. So here's your classic lichen planus. Notice how band-like it is. It really just hugs the epidermis. Usually doesn't go too far down in the deeper dermis, and the epidermis at the beginning can be completely obscured. And the lichenoid reaction in lichen planus really does wipe out the basal layer. At some point, it'll just be completely gone. You can see here, and the whole junction's been obstructed by the lymphocytes. Other places, it becomes a little sawtooth, as you can see here. The hypergranulosis is very typical, and usually it's got orthokeratosis. This one has a little bit of basket weave. It might be a little bit newer. But if you have a lot of scale crust or parakeratosis and you have a lot of eosinophils, people imply that that might be a drug induced lichen planus. So there's lichenoid drug reaction, and in my opinion, we call it the world according to JJH, but I think, and probably others do as well, that a drug can actually cause lichen planus. So I've had patients who have classic lichen planus that went away after I took away their ACE inhibitors. So, but people say if there happen to be a lot of EOs, then consider lichen planus, although eosinophils can be seen in lichen planus. So again, with lichen planus, usually it's very restricted to the top, this very band-like or lichenoid infiltrate. And again, I'm going to have a lot of repeats here. So obscured basal layer, vacuolar change. Here are the little holes here are the vacuoles. Lymphocytes are, completely disrupting the junction. You can see them here. There's hypergranulosis. Shouldn't be too many eosinophils. This one happens to have an eosinophil. Sometimes it can have an eosinophil, especially if it's more the hyperplastic type. And then you get a lot of pigment dropout, which we haven't seen this one. To remind you of the wedge-shaped hypergranulosis. Here you have the sawtooth rete. I think this is very classic. Most people know about this. You can see here, no basal layer here, just the rete's completely wiped out, and you just have this pointy, these are the squamatization, because here, these are the keratinocytes that usually live up here, and the whole basal layer is gone. So you have squamatization, and that just sort of sits on the junction here with a band of lymphocytes. Here's another example of a lichenoid interface reaction, but it's a little bit different. So this is pigmented purpura, lichenoid pigmented purpura. Again, band-like, it usually likes to stay around the superficial capillaries here. A very sort of gentle interface reaction. You can see, instead of being smooth, you can see the lymphocytes are at the junction. There is some vacuolar change. You may or may not see some interface reaction. You've got some flattening of the rete here. So here's, again, evidence of an interface reaction. But this is different than lichen planus. It's not as hypergranulotic. It's nice and basket weave. It's not obscuring and eating away at the rete. And here you have this red cell extravasation, which is typical of pigmented purpura. All right, the vacuolar ones. So connective tissue disease is your typical sort of vacuolar interface reaction. No lymphocytes really here. Here you have a few lymphocytes here. This is mixed connective tissue disease, but this could be any of them. This could be lupus, this could be dermatomyositis. There have been studies to show that histologically, you can't differentiate between these. But I put these up to show you an example of what a vacuolar interface reaction looks like. You can see all the vacuoles here, the alteration of the basal keratinocytes. Here, the basal layer sort of isn't even here again. Again, we have the spinous layer just sitting on the dermis, so you can tell there's been disruption. And and at first glance, you might not think that there's anything going on here, but one of the clues is going to be the presence of pigment incontinence. So anytime you see that, you want to look above to see if there's any sign at all of an interface reaction. And hopefully you guys can see this. Since I'm not looking at your faces, I can't see if you're having nodding or blank stares, but there's a little bit of interface reaction here. Again, just to show you how paucicellular it can be. So from farther away, you can see that the reedy pattern's gone, but it doesn't have a lot of hypergranulosis, maybe some subtle alteration of the papillary dermis, and you can see this hair follicles involved as well. If you go closer here, this one has some dyskeratotic keratinocytes in addition to the vacuolar alteration of the basal layer. People refer to this as liquefactive necrosis of the basal layer, just sort of dissolves. But you don't have a dense infiltrate here. Here's another example of the vacuolar basal alteration. And then you've got the pigment incontinence. Sun-exposed skin, so probably one of the connective tissue disease. You can see the solar elastosis here. I mentioned colloid bodies, so the dyskeratotic keratinocytes will sometimes drop down into the bottom, or the basal layer just sort of dissolves and these colloid bodies start to pop up here. These are these little pink globs here of keratin. And a lot of times you have combined. So this is an example of lichen planus I showed you earlier. And you can see here, even though it's band-like here, it's sort of naked, but you can also see that there has been some reaction here. So this dense band of lymphocytes that used to, look like that, with time starts to show minimal inflammation here. So you can have this combination of changes. Again, you can see here your classic hypergranulosis, interface reaction with colloid bodies, wiping away the keratinocytes at the basal layer, and then here, not much inflammation. But you do have this papillary dermal alteration. And this can sometimes confuse us or make us wonder about regression, which I'll talk to you about a little bit later. Again, here, the spinous layer sits directly on the dermis, so you can tell you've got no more basal layer left here. You might have a few lymphocytes here, but most of them have sort of gone away, did their job and ran away. So a lot of variants of lichen planus or hypertrophic variant, which is commonly seen on the legs, lichen planus pigmentosus, which could either be photodistributed or in the intertriginous sites like groin, axilla, underneath the breast. There are mucosal variants, both in the oral and genital mucosa. Here, there's this white streaky change over the top, referred to as Wickham stria, and the changes can either look erythematous or sort of white. You can have nails involvement with dystrophy, and as I mentioned, you can have medication induced. So just for fun, I put in different types of lichens here, but a lot of these I pulled from the literature. It's always good to have these, not in the literature, but the internet. It's always nice to have these available. So this is from the University of Iowa, which is where I grew up, actually. Here is how it looks in a dark-skinned patient. So you still see the flat top papules, maybe some linearity, but it's not that pink violaceous color. But it has sort of a little bit of a pinkish violaceous hue. Here you have just pigmented patches in the axilla. So this is an example of how lichen planus pigmentosus would look. Lichen planus in the nail just completely destroys the nail bed. You have scarring, and usually most of the nail is involved. Sometimes it can start here. Here's the introitus. You can see it's got erythema and this sort of delicate lace-like white change on the top. You can also have in the oral mucosa. Here's the sort of classic sort of pinkish and red discoloration with also some Wickham stria type change, which you can see better here. This is that lace-like white change you see as Wickham stria. And then sometimes, just like here, it can present with sort of erosive mucositis with just erythema. And you can also see it on the penis in this sort of same violaceous color here. So those are just examples of lichen planus. If you need to do clinical pathocorrelation, remember, it's not always going to look like that. It'll have different presentations. Oh, I forgot, hypertrophic lichen planus, very sort of rough, sort of cobblestone plaques, usually on the leg. So hypertrophic lichen planus, you have hypertrophy usually of the follicular epithelium. So it's the same thing as pseudoepitheliomatous hyperplasia, where you get hyperplasia of the follicular epithelium. So your differential is going to be pseudoepitheliomatous hyperplasia, as well as keratoacanthoma, which is also a tumor of the infundibulum, as is squamous cell carcinoma, at least the follicular type. But the difference is you can see that instead of being smooth and pushing down and having atypia, the basal area is disrupted by the lymphocytes, and you have sort of the jagged area at the edge with some pigment incontinence. Here you have some here too. But it can be difficult to differentiate all these here on the right from hypertrophic lichen planus. So you need the clinical. Here's an example in dark skin patient. It's been referred to as igneous rock or volcanic rock. So you can see some similarities to that. And that's very sort of classic lichen planus, hypertrophic lichen planus. As I mentioned, the wedge-shaped, the sawtooth reedy alteration is very classic, but as I've already shown you, it won't always have that. I mean, if you look closely, you can see there's a little bit of sawtoothing here, but a lot of times, as lichen planus gets more chronic, you can have just complete wiping out and just smoothness or attenuation of the reedy. And then here you can tell that there's been something going on. There's a lot of pigment dropout. So I think this one won't be too difficult to differentiate from, just normal skin. And you can hopefully recognize that there is a lichenoid tissue reaction. But this, this naked interface could be a lot of different things. Lupus, maybe lichen sclerosis, fixed drug. Again, the pointiness of the reedy might help you, but overall, it can be difficult to differentiate. But if you go to the clinical and you can see they have these really hyperpigmented patches on the intertriginous sites, then you know that this is lichen planus pigmentosus. Again, clinical pathologic correlation is key. Here again, you can maybe have the active interface change, but a lot of times you might just get a biopsy that shows sort of an end stage or later stage lichenoid tissue reaction. A few lymphocytes are still here. As I mentioned, the differential can include regression of a melanocytic neoplasm, usually melanoma. And you can see here on a Verhoeven-Giessen elastic stain that you've lost elastic tissue here compared to here, although it has a delicate interface here where there's a change of the elastolysis and the intact elastic tissue. And that's more typical of a benign regression. So this is just another example of lichen planus pigmentosis. This was under the breast. Lupus erythematosus is another example of something that might have a combination of interface plus more of a lichenoid infiltrate. Here's your classic interface reaction that you can see in subacute cutaneous lupus. Some disc keratosis here, vacuolar change, also some perivascular infiltrate. Probably some mucin here. Sometimes you can't see it. You have to highlight it with a colloidal iron stain. Different labs are, may have more or less mucin on their H&E stain sections. But here, an example where it can be denser sometimes in lupus. So they won't always have the naked interface reaction. This is probably a little bit more acute. Vacuolar change, lymphocytes disrupting the basal layer. Lupus, a lot of times you can have some red blood cell extravasation, as you can see here. So going to the architecture of the infiltrate, we'll sort of stay with lupus here. So from afar, you can see that there's a lichenoid, or there's a lymphocytic infiltrate that's around some of the vessels, but it's not that wedge-shaped because it's not involving this area too much. It's a little heavier here, probably corresponding to this pilosebaceous structure that's going to pop up in another couple levels. So if you have sort of a superficial and mid to deep infiltrate, maybe heading around the adnexal structures. You got to think of lupus. Here again, more of the same. This is the one I showed you earlier. This little heavy image is a little blurred. I think it's didn't used to be blurred with time with compression. I think it's gotten a little blurry. And then you can see it around the hair follicle and also with mucin in the dermis here. Lupus, a lot of times will have a lot of pigment dropout, especially if it's in a dark skin patient. The hair follicle has a gentle interface reaction similar to what you'd see in the epidermis with lymphocytes picking at the edge of the follicular structures. So it might be some subtle interface change plus a dense band of lymphocytes around it, and then a lot of pigment dropout and some basement membrane thickening. Here you can see also another example of lupus heavily involving a hair follicle here. Sometimes you'll have early follicular plugging that'll look looser. It can get a little denser with time. Here's another example of discoid lupus erythematosus or chronic cutaneous lupus. You start getting a lot more hyperkeratosis. You start getting some follicular plugging. You've wiped out the basal layer. It also extends around to involve the hair follicle. Graft versus host disease, usually acute. You can see basically stratum corneum, a gentle interface reaction, usually has, a decent amount of keratinocytes that are involved here. And then you can see this is in another level with a hair follicle, but GVH also likes to involve hair follicles as another little clue. Going along with the architecture of pityriasis lichenoides being perivascular and band-like. Again, it sort of obscures the reedy but doesn't wipe it out like with lichen planus usually. And you have the infiltrate trickling around the vessels and sometimes the adnexal structures. Here's just another example. This one's a little heavier with the infiltrate here, but you can see it's starting to have a little bit of scale crust, which is typical of pityriasis lichenoides. Again, you get the lymphocytes start going up into the epidermis and associated with parakeratosis, another classic presentation. Band-like perivascular with scale crust. Just to drive the point home, here's you got your scale crust. My clue when I was a resident and got these as an unknown was to see red blood cells that were trickling into the epidermis, but usually you can just see them in here. So that's another component. Lymphomatoid papulosis can also have a band-like and perivascular infiltrate and present as a wedge-shaped infiltrate similar to pityriasis lichenoides. Lichen striatus also has a classic architecture with variable epidermal changes. Sometimes it can even simulate mycosis fungoides. Doesn't usually completely wipe out the reedy like lichen planus, but this has classic involvement of the eccrine coils. As you can see here, this one's a little bit more lichen planus-like, but the differential will be sort of determined by looking at the deep elements of the rash and seeing of the biopsy and seeing that it involves the eccrine coils. So this is another classic band-like and perivascular presentation. You can see it's band-like and it doesn't quite wipe out the reedy like you see in lichen planus. It's sort of there, but it's a little foggy, sort of a blurry. So it's a combination of lymphocytes and histiocytes that makes it just sort of blur the epidermal process. Usually there's some hyperplasia here, but this sort of band-like, messy, dirty dermis that's perivascular also. So histiocytes, lymphocytes, and obviously, as you know, plasma cells usually, not always, will be syphilis. Here's another example. Just a very busy dermis, like almost looking through a fog, and you can still see the reedy, but they're a little blurred by the lymphohistiocytic infiltrate. All right, the pattern of the interface reaction, we sort of talked about this already. Just sort of some vacuolar change, this liquefactive necrosis is sort of a little bit more characteristic of connective tissue disease. This happens to be dermatomyositis, but as I mentioned, connective tissue disease all overlap. Here, as you get chronicity, you start to get reduplication of the basal membrane zone, and here you have this thickening of the basal membrane zone. You can see the follicles involved here. So this pattern that's really involving the follicle, a lot of chronicity, you put lupus in the differential at the top. Sometimes it can be more acute and have a lot of dyskeratotic keratinocytes. This is a patient with acute lupus, but the differential on this would include something called Rowell syndrome, where they have clinical and histopathologic lesions that overlap with erythema multiforme. Sometimes you can get so much necrosis that the whole epidermis is lifted off and very pink. You don't see the same distinct keratinocytic outline anymore as it becomes more eosinophilic and necrotic here. So this, and there's vascular stratum corneum. So this is an acute hit to the epidermis causing full thickness necrosis due to prominent dyskeratotic keratinocytes that you can see here. So this is something that would be sort of classic for toxic epidermal necrolysis and Stevens-Johnson syndrome, but can also be seen in fixed drug eruption and erythema multiforme. Satellite cell necrosis refers to usually two, but sometimes you can only see one of them, lymphocytes, really approximating the dyskeratotic keratinocytes or apoptotic keratinocytes or savant bodies, whatever you want to call it. So this is very classic for graft versus host disease, but it's not completely pathognomonic. Or restricted to this diagnosis. You can see it in some of the other conditions. But if you see a lot of this, and if it's a test question or something, and this is on the list, I'd probably pick this one. But you can see the junction is completely obscured by the lymphocytes here with a lot of dyskeratosis. Associated epidermal changes. We already talked about the hyperplasia you can see with hypertrophic lichen planus. If you just got part of this, you could wonder about well-differentiated follicular squamous cell carcinoma, but here there's a dense band like infiltrate that's causing the typical reedy destruction consistent with lichen planus. But remember, you have to still correlate it with the clinical presentation. Alteration of the epidermis by scale crest, as I mentioned. So you get the parakeratosis, you get trickling of the lymphocytes and serum into the horn, and you can see the junction is obscured by the infiltrate, but doesn't completely wipe it out like you'd see in lichen planus. I already mentioned the basement membrane zone thickening, which you can also highlight with a PAS stain, which I told you there. And this, it's hard to find a good example of it, but this is really quite a good example of this basement membrane thickening. And then red blood cells is also a feature I see in lupus a lot. Spongiotic changes, so you could have an interface reaction that also has spongiosis, and to have the combination of different histopathologic present conditions, spongiosis plus interface. A lot of times we'll put you in a drug induced process diagnosis. I mentioned a lot of dyskeratotic keratinocytes. A lot of times you think of Stevens-Johnson, erythema multiforme, fixed drug eruption. Again, overlap with all of these. And acute, you can tell because of the vascular stratum corneum. Sometimes it can be so disrupted here off to the side. You see this interface reaction just completely blowing away the keratinocytes at the base, and it separates from the dermis. So you have a blister induced by, again, all of these conditions. Sometimes we'll get a biopsy and it'll be sort of a lichenoid dermatitis, but then we keep going. I gave you an example that wasn't quite as classic, but here you see a break in the granular cell layer with some dyskeratosis, with hypogranulosis, some dyskeratosis. So this is an example of poor keratosis that can be subtle, but that can also be a cause of a lichenoid infiltrate. And then you can also sometimes see some maturation disorder, maybe a little bit of atypia within the epidermis, and then these sort of splat mitoses or these ring-like mitoses that have not completely specific, but have been described in various drug eruptions, including taxane, efortumab, vetoin, and colchicine. So if you see those ring mitoses, you got to think of those as the cause. Annular dermatitis of youth has a very classic blunting of the reedy. You can see the base of the epidermis of the reedy is completely wiped out, and there's this sort of a rhomboid shape or claw shape to the base of the reedy. And then sometimes you can have a combination of the interface reaction plus acantholysis. And so here you see some acantholytic keratinocytes. They ball up as they separate from one another, plus the interface reaction. And that combination would put you in the camp of paraneoplastic pemphigus. So looking at the composition of the infiltrate. So pityriasis lichenoides, it is lymphocytic and pretty much strictly lymphocytic. People have looked at, I think this is, I don't know if that's blocking for you guys, but people have looked at this and found that they really don't see eos in pityriasis lichenoides. So if I start to see a lot of eosinophils, I will wonder more about a pityriasis-like drug eruption. If you do see a lot of EOs, you of course want to think about fixed drug eruption. This is sort of an eosinophil party, and this is more than I usually see in fixed drug eruption. But again, this will put you in that category. Plasma cells, as you know, would be a clue to syphilis, but a certain percentage of the cases, maybe 10 to 20 or so, will not have plasma cells. So to me, syphilis is going to be sort of a lymphocyte and histiocyte infiltrate. Sometimes you even get some granulomatous features. But again, if you see an interface reaction with plasma cells, you have to think about syphilis. If you have, these little circular collections of lymphocytes, especially they've wiped out the rete, and then the rete start to sort of surround it and sort of have a claw-like presentation around a ball of inflammatory cells that include histiocytes and granulomatous cells, then you got to think about Lichenitis, which is going to present with a lot of little tiny little papules all over the body. And then lichenoid tissue reaction with some cytologic atypia. Now, this could actually be an image of lichenoid keratosis because you can see some atypia in that, but this happens to be a patient with lichen planus. So again, you want to look for atypia in these situations. And then dermal changes. I mentioned red blood cells as a feature of pityriasis lichenoides and pigmented purpura, although they're going to have different histologic architectural presentations because PPD will be strictly band-like for the most part, and pityriasis lichenoides goes around the vessels. Fixed drug eruption will have pigment. I already mentioned a couple other conditions that have pigmentation. If you see something that has pigment dropout plus a little interface change, so see how that's a little ratty, a little smudgy. It's not a nice smooth basal layer. So this has had a little bit of an interface reaction that's a little bit maybe older now. But stratum corneum is basoweave. It makes you think, usually if you see a lot of pigment, it's going to be a chronic condition. But this is from the previous hit. The fixed drug eruption occurs when somebody takes a medication and then it causes an inflammatory interface reaction that causes pigment dropout, and then it goes away on its own. But then when you take the drug again, it's usually a little bit of a delay. It's not every single time you take the drug. And it can even be a food too, but then it will hit it again. But this is a biopsy taken from a pigmented lesion, probably, or maybe a later stage. Erythema dyschromicum perstans will also present with pigment incontinence. The interface reaction tends to be very subtle here. I sort of picked the worst part. You can see it's got a jagged basal layer here, a little bit of ratty, but usually won't have much inflammation here. So sometimes it's just the pigment in the dermis that will give you the clue. Here again, you see, God, these look blurry to me, but maybe it's my eyes. But anyway, here you can see it's ratty here along the base of the keratinocytes with hardly any inflammation, but the pigment dropout is going to be your clue. And then for erythema dyschromicum perstans, you really have to look at the clinical presentation. If the pigment is very deep, it'll look a little bluish, but it's usually not quite as hyperpigmented as lichen planus pigmentosa. And it's also not restricted to the intertriginous sites. A lot of times it can just be sort of on the trunk. But again, you have barely any inflammation. Your clue at low power is going to be some pigment dropout, maybe absence of rete. And then when you look closely, you can see this ratty basal layer, which can be very subtle. I had to, make sure I got a nice picture of what it should look like for you there, but sometimes it's hard to find. Lichen sclerosis can present with a prominent lichenoid tissue reaction, not always, but it's going to have this pattern of sclerosis, this smooth they refer to it as homogenized, but the smooth sclerosis, and then the lymphocytes may or may not still be in the picture. Here, there's a little bit left here. We're still on the dermal changes, so we look for dermal hyaluronic acid or mucin. If we want to look for dermatomyositis and lupus erythematosus, you can highlight that with Elsham blue or colloidal iron. And then a few miscellaneous things. I mentioned the lentigo at the edge of a lichenoid tissue reaction in lichenoid keratosis. Sometimes I see this affecting a large cell lymphoma. Some people don't believe in that, but it's a real thing. Anyway, but so at the edge, you can sometimes see residual of that lesion. Here's a brisk lichenoid tissue reaction. You can see here, very dense, some hemorrhage. And this actually is a hair follicle that, if you look closely, has viral cytopathic changes. This is a multinucleated cell with margination of the chromatin. You can see these virally infected cells. So on occasion, you can see a lichenoid tissue reaction with zoster or sometimes herpes simplex. So again, ClinPath correlation is important. And we mentioned lichenoid keratosis, even though there can be a lot of atypia sometimes in this, it's usually just a single lesion. Sometimes there's a background of solar lentigos, and it's been a little bit of a hit here, but it caused it to be sort of violaceous. It clinically looks like a basal cell carcinoma a lot of times. As I mentioned, with lichenoid keratosis, it can be variable. Sometimes you might see something that looks like almost nothing, and you might, this is really extreme, but sometimes you might get an early one where in one level you might only see this, but if you get deeper levels, you'll see some interface change popping up. But again, it's always a good exercise to look at the LKs, because you can see the different stages of the interface reaction. So here, the rete are still rounded, some junctional lymphocytes, and then you can see they start to wipe away the rete in a way that's similar to lichen planus. And here you got also the same sort of lichenoid tissue reaction. So you can have all the different phases within a lichenoid keratosis. Again, you can see here, and some of these are colloid bodies that have dropped down. Sometimes your clue will only be some colloid bodies, and they can just look like these subtle little pink things, but this one's a little bit obvious here. They're sort of on their way into the dermis. They haven't quite made it to the end of the journey. It's referred to as lichen planus-like keratosis. So you can see here it's very lichen planus-like, but a lot of times it's not going to have the lichen planus features. It can just have a variety of different features that I showed you. This is just another one showing that the basal layer might have started to repair itself already. So that doesn't have too much. There's some vacuolar change, but you can see that the dermis has this smudginess that probably represents some chronicity, and then also some colloid bodies there. And later stage, as I mentioned, you'll have a lot of pigment, you'll have some alteration, pigment dropout, and you might not have the infiltrate there as well. And so this image here could be seen in a regressed melanoma. You got some tumoral melanophages here. And so sometimes we can't tell if it's regressed melanoma or not. The clinical presentation often can help you. But sometimes it's a little bit more broad than we're used to seeing in a lichenoid keratosis. And we do sometimes have to wonder, could this be a melanoma? We can look to see if there are melanocytes here, but sometimes it's hard to tell. So it can be indistinguishable. I'll sometimes say, late lichenoid tissue reaction could be regression of a pigmented lesion, which could be a lentigo or a melanocytic proliferation. I won't always throw melanoma words in there to frighten people, but we can sometimes do some markers. So I showed you before, you have elastic tissue loss. It's just a gentle transition between the area of the elastic tissue loss and the regular dermis. And years ago, Hideko Kamino nicely showed that in melanoma, this is taken from the article, in melanoma, it sort of pushes, probably as melanoma has grown and then regressed, it has pushed down solar elastosis. So you get more of a solid area of regressive type change. Here's another good example here. So I find this to be helpful. You can also look at the melanocyte pattern with SOX and PRAME. So here, in a lichenoid keratosis, you have usually retention of the melanocytes. It's relatively equidistant. Sometimes the lichenoid tissue reaction can really mess these up a little bit, and they can even nest up a little bit and look like a melanocyte lesion because it's got a nest, but it's from just the disruption of the keratinocytes. And then, even though sometimes people don't like PRAME because it's nonspecific, but it is helpful when it's completely negative to help support your, calling it benign. In fact, Dr. McNiffen and colleagues, this is that sort of pseudo nest. It's real melanocytes, but sort of a pseudo theque or pseudo nest. And they showed that PRAME was helpful in helping to define this as being a benign process in these melanocytic pseudo nests that you see in the lichenoid tissue reaction. So that can be helpful. So here's another example, sort of lichenoid infiltrate. You've sort of wiped away the basal keratinocytes here, marked lichenoid tissue reaction. So, rule out LK versus other. On a bad day, you could say LK. But if you look closely, there are actually some melanocytes trickling up there. And so this just shows you that it can be really tricky. Sometimes you can have a lichenoid reaction to a melanocytic lesion. And this actually was a melanoma with a brisk lichenoid host response. So you do have to look carefully. If I stain this with markers, of course, these would all pop up. Here's another lichenoid tissue reaction, a dense infiltrate. And here you can, now that we've already seen that, you can have melanocytic cells involved or melanocytes, we look closely and there are some melanocytes here, maybe even some bridging. And then this dense host response, you can see the lichenoid tissue reaction. And here, you can even see here that there are some cells in here. They're sort of in nests. And in case you can't see them, I outlined them for you. And this is actually a halo nevus. So sometimes a halo nevus can make you wonder a little bit about a melanoma, but it doesn't have too much in the way of atypia within the epidermis. And so sometimes you can get a brisk lichenoid host response to a nevus. You may or may not have the clinical halo depending on how long it's been going on. But that's all. Halo nevus is also in the differential lichenoid tissue reaction. Oh my gosh. I have a lot to show still. I'll just go fast. Rafal, you can tell me if I need to stop. But we're going to go on. So now we're doing a little bit more diving into some of the clinical presentations. So since I told you had to do ClinPath, I'm going to show you at least some examples of some common things. So lupus erythematosus presents a lot of different ways, but usually it's in some way photodistributed. So here's acute cutaneous lupus, very serpiginous, very polycyclic, and annular, that violaceous color, sort of in the photodistributed area. Again, in a dark skin patient, you're going to have different colors. So here you have hyperpigmented plaques. You can see they're probably a little scarred down. So these would be example of the chronic cutaneous lupus or the discoid lupus with some hyperkeratosis. In the ears is a really good place to look for lupus. And a lot of times, if it's a little bit burned out, I told you earlier, you have a lot of pigment dropout. So you have a lot of dyschromia, hyperpigmentation, and then pigment loss. And you can see here example of in a dark skin patient, a lot of dyschromia here, and probably again photodistributed, not under her neck but on her chest. And then in the scalp you can see alopecia, and then if you look closely you see a lot of plugged hair follicles. So follicular plugging is also common. And again, I've already shown you this picture. You have dyskeratotic keratinocytes, radiate basement membrane zone, erythrocyte extravasation, basement membrane thickening of lupus. Again, here's an example. Sometimes you won't have too much in the way of an interface reaction. So this is an interface talk, but sometimes you won't have any, but you'll have this dense infiltrate around hair follicles and eccrine coils. And this is an example of more of the tumidus presentation. If you look closely, there will often be a little bit of an interface in tumid lupus. With lupus, you tend not to see eosinophils, although if you see it and you still think it's tumid lupus, it can still be lupus. You can have some eosinophils. But the infiltrate tends to be very tightly lymphocytic. So you see here, it's a lot of little nuclei all close together, not a lot of spaces like you'd see in between the nuclei if it were a histocytic infiltrate with the cytoplasm. And you can see mostly just small lymphocytes with some mucin. This isn't done all that much anymore, but direct immunofluorescence can show some classic findings, usually multiple immunoreactants in a granular fashion deposited along the basement membrane zone and around the follicular basement membrane zone. If this is on a non-sun exposed site, it had classically been referred to as lupus band test. And now it's not used for that reason anymore because we have the double-stranded DNA that can be helpful in diagnosing lupus. Dermatomyositis. So to differentiate these connective tissue disease under the microscope, you can't, so you have to go to the clinical. So here's some classic dermatomyositis images, which I took from this article. But you can see this ratty cuticle with telangiectatic mats, these Gottron papules, or these very circumscribed areas of violaceous pigmentation over the knuckles. You can have the same concept over the big knuckle, the elbow. The heliotrope rash, this violaceous sort of pinkish purple color, again, usually sun-exposed skin, and poikiloderma, hypo and hyper or erythematous patches with increased vessels, again, sun-exposed usually. This is, I don't know why it's a little bit here, maybe it just was a crease. Oopsie, sorry. And then underneath the microscope, this is a study showing that really you can't differentiate between acute lesions of lupus and dermatomyositis. If you have that chronic cutaneous discoid type lupus, that's going to be usually more easily differentiated from dermatomyositis. So these are sort of, one's dermatomyositis. I don't see my label. Yeah, one was dermatomyositis and one was lupus, but my label, I don't know where it went. It's in there somewhere. Sometimes the colors go from white letters to black letters and I can't see them anymore. But bottom line is you can't differentiate. You have to go with clinical. McNiff and colleagues at Yale were able to show that in lupus, you can see clusters of CD123 or the plasmacytoid dendritic cells. And if you have a lot of them, and especially if they're deeper and in clusters of, let's say, 5 to 10, then that's going to be more in favor of lupus than dermatomyositis. You can see just a few solitary ones here. This is another author, Tomasini, who showed also that you can really have these large clusters of plasmacytoid dendritic cells, usually over 10. If you sort of have that over 10, and some studies say over 20, then that helps you to firm up more of a lupus presentation. And here in contrast, you can see Lichen planus with just some solitary ones. Now, this will also stain vessels. So you have to be careful if you're trying to, count just color areas. You really want to see the cells lighting up. Here's an example of lupus on the scalp that I showed you. Here's just another example here with more plugging. Now, in contrast, Lichen planopilaris will also have an interface reaction. So here, it is also going to involve the epidermis. It sort of picks at the edges of the hair follicle. And here with Lichen planopilaris, you have this very classic mucinous degeneration. So you get this light purplish edematous change to the adventitia around it. You get this classic thinning of the follicular root sheath. You may or may not have some plugging. You can have a little bit of involvement of the interface, whether that's true interface or another hair follicle in, coming up next in one of the planes of section. It's not clear. But this is striking, usually eccentric thinning of the follicular root sheath is going to be more typical for Lichen planopilaris. The other feature, again, you see here, the epidermis is more acanthotic and not atrophic like you'd see with lupus. Again, the eccentric thinning of the follicular root sheath with the loose myxoid perifollicular fibrosis. And then here you can sometimes find a follicular scar. So this vertical orientation of a collagen alteration, here's normal collagen, here maybe with some abnormal elastic tissue, this will be a follicular scar, which will also be your clue. The plasmacytoid dendritic cells has also been helpful in differentiating lichen planopilaris from lupus. So again, if you have more than 5, this can be more typical for that. Hypertrophic lichen planus and lupus erythematosus can sometimes look similar under the microscope. But again, the rough sandpaper-like, volcanic rock-like plaques on the legs are going to be lichen planus. Here, they looked at keratinocyte proliferations to differentiate from lupus, and they found that, again, this clustering of the plasmacytoid dendritic cells was helpful in differentiating lupus from well-differentiated squamous cell carcinoma. And these authors show the same thing, and they looked at, they also looked at, I think, keratoacanthomas and squames in their study. Okay, moving on to drug-induced lupus. Histologically can look very similar. It will tend to have eosinophils, but that's not going to be able to differentiate. You just have to see if they have any drugs that might be implied or implicated in this condition. Here again, we have an example of drug-induced lupus involving hair follicles and junction with erythrocyte extravasation. So to me, this has all the features you can see in lupus. Here, they looked at subacute drug-induced subacute cutaneous lupus erythematosus and idiopathic lupus. And, they listed a lot of different drugs, usually the diuretics and biologics. These are sort of the groups of conditions. And as far as the single causes, like some specific causes, hydrochlorothiazide was a big cause. The drug we use a lot, terbinafine, can also cause it. So remember that. They couldn't find that much of a differential, that much in the way of differentiating these. Leukocyte classic vasculitis was seen a little bit more in drug. These patients were older, had more systemic complaints. And with idiopathic, they tended to have more mucin. And then when DIF was done, they did find some typical basement membrane zone staining. So maybe DIF might be good in that situation. But in the end, I think it's still good to look to see if they have a drug trigger. Now, sometimes the drug can unmask lupus. So you have to also realize that could be the case. You might stop the drug and they might still continue to have their lupus condition. And with drug, you can also see positive Rowan loss. So that's not going to necessarily put you in the idiopathic camp. Here's just an example of drug-induced lupus from Lamisil. This one has a little more spongiosis, so that might put you more in the camp of drug. As I mentioned before, a combination of spongiosis and interface change could be more drug. And then here's the example of a drug reaction. I think some of this might be from the other patient, but here's the Lichenoid drug eruption here that has more of an interface plus perivascular, the mix of changes with an eosinophil. And these lesions are a little lichen planus-like. That flat top papule looks a little shiny because it's flat topped, and that's how it photographs with the reflection of the light. But this patient had been on meds, and it's not like a drug hypersensitivity reaction, like you took the drug last week and I have a rash. It's usually a little bit more sort of long-term that you've been on the drug. Graft versus host disease. This occurs, as a consequence of transplantation. There are acute and chronic presentations. They overlap. There's no longer a time cutoff for these. So acutely, you have these characteristic skin findings that could be sometimes just look like a regular rash, but you also have GI liver abnormalities, and then no features of the chronic GVH. So here are some features that can overlap with any drug reaction on the right that are acute graft versus host disease. And chronic graft-versus-host disease is defined by having at least one of the diagnostic features here of the sort of typical findings in graft-versus-host disease. And you can have overlap of chronic and acute, but if you have some any chronic features, you put that sort of in the chronic GVH category. And here's a list of these here. It can overlap with lichen planus, with lichen sclerosis. Again, these people have other systemic conditions, especially GI. So here's the example I gave you of graft-versus-host disease. Remember the satellite cell necrosis. You can have eosinophils, so you can't necessarily use the presence or absence of eosinophils to differentiate drug from graft-versus-host. And we're those of you who see these biopsies, not everybody does, but usually we're asked to differentiate it from drug, and honestly, you can't with certainty. This group looked at blindly looked at some acute GVH cases, and they found that maybe more spongiosis and a lot of eosinophils would be more more in favor of a drug. So a lot more sponge, a lot more EOs can be drug, but if you can have EOs, as I mentioned, in graft-versus-host disease. Subacute radiation dermatitis is not that common. It has histopathologic features that can overlap with graft-versus-host disease, with lupus erythematosus, with fixed drug eruption. And this is actually due to radiation, not from the site. So you don't have radiation here. And if you ask if they've been radiated, they're going to say no, because it was really due to sort of a prolonged radiation exposure, usually from a GI study or angioplasty or something, and it sort of shoots through the body into the back, and then you get these interface changes that really are indistinguishable from other conditions like graft-versus-host, lupus, and fixed drug eruption. Moving on to fixed drug eruption, as I mentioned, you have these recurrent rashes that is really just a circumscribed area of erythema. Sometimes it's extremely round, and it can be at variable places. Penis is a place where it's often seen, face, but it can really be anywhere. And then you get this lichenoid tissue reaction, which I've already gone over with you. Here is examples again. It is sort of acute-ish, can be around the vessels too. Erythema multiforme will not be hitting the deeper vessels. So if you see a lot of deeper vessels, you might think of this with eosinophils. Again, I showed you this example. Again, your typical interface reaction, you may or may not have like a little satellite cell necrosis there. Your clue is going to be pigment dropout plus more of a basically stratum corneum. The acute ones tend to have a lot of disc keratosis. These are more of the pigmented lesions. Here, more acute, a lot more disc keratosis. This one is the one I showed you earlier with the eosinophils. Now, sometimes it can actually have a lot of neutrophils. So here's your classic sort of older lesion. Probably it's had another hit recently because it's a little bit pink in addition to being brown. And this is a myeloperoxidase. So sometimes you can have a lot of neutrophils in a fixed drug eruption. So it sort of breaks the rules. This is another example with a lot of neutrophils, your classic. Sometimes it looks a little bit dusky. So the old pigment dropout plus the new hit from the having just taken the medicine again. And so sometimes you have neutrophils, although these authors looked at this and they felt, in looking at a whole bunch of theirs, that the neutrophil component might just be a factor of an early lesion biopsy. But don't let neutrophils dissuade you if you think it otherwise might be a fixed drug eruption. Erythema multiforme is diagnosed, I think, especially by the morphology of the clinical lesion, which tends to be a targetoid plaque or targetoid lesions, usually a bit of a plaque or patch. Depending on where you take the biopsy, if you take it here, you're just going to get an interface dermatitis. If you take it here, you're going to get necrosis and a blister. So you have the full thickness necrosis because it probably came from the center. Whereas if you took it from the edge, you're going to have more of an interface reaction. A lot of dyskeratotic keratinocytes are typical of erythema multiforme. Stevens-Johnson, TEN, again, this is sort of defined by sort of more extensive body involvement, but the classic presentation is going to be full thickness necrosis of the epidermis. So even this can be done as a frozen section. You can gently take off the blister or denude it and do a frozen section on it and see that. So again, these can all look identical, but fixed drug is defined really by its circumscribed nature. However, it can be widespread. So there have been cases of fixed drug eruption that look like Stevens-Johnson syndrome. Here, just I'm not going to go through this. You can, I guess, look at it later, but you can see they've tried to show different features that can differentiate erythema multiforme and Stevens-Johnson TEN. So it sort of has to do with sort of how much mucosal involvement you've got, how much body involvement. Tends to be more acral with erythema multiforme. They tend to be older with SJS. Erythema multiforme tends to be more associated with the herpes. And so here you can sort of look at this chart later on to see some ways to differentiate. I did mention fixed drug can be bullous, and in this situation, you do have to, if you have generalized bullous fixed drug eruption, you do have to consider this in the differential of TEN and Stevens-Johnson syndrome. You'll have less constitutional symptoms. It'll have a shorter latency for fixed drug eruption. But again, I've seen, and there have been in literature reports of generalized bullous fixed drug that have been considered otherwise to be erroneously to be Stevens-Johnson. Reactive infectious mucocutaneous eruption due to various viruses, in this particular case it was COVID-19, can have sort of erythema multiforme-like lesions, and for all the most part, it looks like typical erythema multiforme with a little bit of mucositis, prominent mucositis and a little bit of body involvement, not a whole lot like the SJS, but a few scattered targetoid lesions. And the difference with Lyme or reactive infectious mucocutaneous eruption, it used to be called MERM because it used to be due to mycoplasma, but now they expanded it to include other viruses, and so now it's called Lyme. But with erythema multiforme, there are lymphocytes. But in Lyme, at least in my experience, they've been more myeloid. So here you have the classic mucositis. It's usually, and this is usually in young people, with just scattered erythema multiforme-like lesions. And then here you see this brisk interface reaction here, but these are really almost like histiocytes. They're histiocytoid because they have the pink cytoplasm of a neutrophil. And you can see here, myeloperoxidase is positive along all these cells at the junction, whereas lymphocytes are sort of minimal. And they also are positive for CD68. So there's sort of an immature myeloid cell here that you can see, sort of like, we're not going to talk about sweets today, but histiocytoid sweets can have the same symptom, same cell type. So again, Lyme, you have changes that look just like erythema multiforme, with interface reaction that can often cause a blister, just like a regular erythema multiforme-like lesion. A lot of dyskeratotic keratinocytes, but the cells are a little bit odd for a lymphocyte. And again, here, it almost looks like neutrophils here. And then you stain it, and it's positive for myeloperoxidase and not for lymphocytes and CD68. So that's Lyme. Immunotherapy-induced lichenoid dermatitis. I think we know now that patients can have lichenoid mucocutaneous eruptions due to anti-PD-1 and PD-1 ligand immunotherapy, and it can have all sorts of presentations, as you can see here. Sometimes you can see it with the combination as well. And the onset is usually around average 4 months. It can be a little bit sooner. And it's something that you can treat through. So it is a reaction, but it's not something that's devastating. And usually they need to have their medicine. So you can recognize it usually just like Lichen planus a lot of times with the infiltrate hugging the epidermis. It may be you might have some spongiosis and some other features. But when I've seen it, it's been very Lichen planus-like. You can see it really hugging the epidermis. This one is not as pointy as you would have with Lichen planus because it's in the mouth. Sometimes you won't have the same lichenoid tissue reactions in the mouth as you do in the skin. But again, here, very lichen planus-like. I'm just going to sort of go on. I wanted to talk briefly about this medicine that's used to treat urothelial cancer, and it's called enfortumab vedotin, and it's an anti-Nectin-4 drug, which also can be seen in keratinocytes. So you can often have a reaction to the keratinocytes as well. In fact, it's very common to have reactions that can be almost sort of this symmetric drug-related intertriginous or S-drive-like. They can be bullous. I'm giving a lecture. It can be bullous. And you can have even palmar erythrodysesthesia. You can have a lot of different ways this can present clinically, but it has a very unique histology. Here again, you have some erosions. This is one I mentioned earlier with the ring mitotic figures. So here you can see a marked sort of a lot of maturation disorder of the keratinocytes. And then if you look closely, you have these ring keratinocytes. I'm sorry, ring mitotic figures here in the epidermis with some maturation disorder and some interface eruption here. Again, you can tell from low power, it's an interface reaction. Then if you look higher, you find these. Remember, you can see these in taxane also and in colchicine, excuse me, colchicine. You can even see it involving the hair follicles. Here's another one. All right. And just in case you didn't see it, I'll show you one more time there. And then lichenoid mycosis fungoides, we usually differentiate mycosis fungoides from a lichenoid tissue reaction because it's band-like, but it does not involve the interface. Pathogenic microabscesses, atypical lymphocytes, in conjunction with lichen planus, which completely blurs the interface. So that's how we usually differentiate MF from, a lichenoid dermatitis. Sometimes you can have it beading along the base of the epidermis, but it's on the epidermal side, and each of these have a halo around it, so we refer to it as lymphocytes in every hole. Marked, epidermotropism here of these atypical lymphocytes, in contrast to destruction of the basal layer in a benign lichenoid dermatitis. Also, again, it tends to be very band-like, but not really causing sawtooth alteration of the reedy. Here, a lot of times with MF, you get these little skinny reedy. But there are rule breakers, and so sometimes mycosis fungoides can present with a lichenoid interface reaction. So this is an example of lichenoid mycosis fungoides, and it is really disrupting the basal layer here, dyskeratosis here, vacuolar change. But there are also a lot of atypical keratinocytes here. And something like this, I don't just say, oh, it's lichenoid MF. You have to work it up with immunostains, which I won't have time to get into now because I barely have time to get through this lecture, and clinical pathological correlation. But this is just to show you can have atypia in lichenoid mycosis fungoides. So you can have lichenoid tissue reaction in mycosis fungoides. You look for areas of atypia. Here you can see these jagged hyperchromatic lymphocytes making a punctuated microabscess. So sometimes you can find little clues, but it's usually clin-path correlation that's required if you're going to make this diagnosis. Pityriasis lichenoides, we already talked about, combination of interface plus perivascular. Clinically, these are small lesions that become erythematous, very smaller than nummular lesions. They dry up and eventually go away. So they will always go away. Sometimes it takes a little longer than pityriasis lichenoides. We already went over the classic interface plus perivascular plus erythrocyte extravasation. Here's your clue here for the diagnosis. Usually no atypia here. We already went through this, the obscuring of the junction, but not wiping away the reedy, scale crust, red blood cell extravasation. We already went through all these. Sometimes you can have atypia. So these are a little bit hyperchromatic and a little bit of atypia. There is some dyskeratosis, some lichenoid tissue reaction. But again, there can be overlap with MF and chronic pityriasis lichenoides. The hemorrhage will help you, the scale crest will help you, the perivascular part will help you, but what is most important is the fact that these lesions are small and they go away. So they might have a chronic eruption, but the lesion itself will clear up. And don't try to check this for clonality because pityriasis lichenoides is often clonal, so that's not going to help you. Lymphomatoid papulosis, a similar pattern of infiltrate, as I mentioned. You can do stains to show that it's CD30 positive, but then the clinical presentation is going to help differentiate this from the others. You have these crops of these papules, red papules that self-resolve going through a crusted phase. Syphilis, talked about sort of a loose band-like, loose sort of interface reaction. A lot of times it doesn't wipe out the interface, it just sort of blurs it because it's got a lot of exocytosis at the base. Swollen endothelial cells, plasma cells, a histiocytic component also. So those are going to be some of your clues. Here's just another example, band-like. Interface, just sort of blurred. You can sort of see in the background the reedy popping up a little bit. It'll have the same pattern as pityriasis lichenoides, but again, the histiocytic component is going to help you differentiate syphilis. And that sort of dirty histiocytic and lymphocytic busy dermis is going to also help you give you. It's not going to help give you syphilis. It's going to help give you the diagnosis of syphilis. And then the plasma cells, but you can't rely on them. Now, clinically, it can do all sorts of stuff. Tends to have these sort of copper-colored papules, sort of reddish brown. And it's key to look at the palms because this will be a clue a lot of times. And you can't say, oh, they're 85, they probably don't have syphilis. 95, whatever, it doesn't matter anymore. They could still have syphilis. So if you think it might be, you just got to check the Wart and Starry stain or the, I think people now are using more the immunohistochemical stain for spirochetes. Pigmented purpura, also band-like infiltrate, with gentle involvement of the junction. You don't always have to have it, but there is a variant of that. And you have these rust-colored brawny patches, usually on the legs. You can have sort of a gentle, mild interface reaction with erythrocyte extravasation. You can stain it for iron. Sometimes an early lesion may not have iron yet, but that's sort of classic. Again, here, sort of the erythrocyte extravasation in the upper dermis with a vacuolar change. Lichen aureus is sort of a variant, but it's more of a solid, brawny patch. Similar pattern, maybe a little denser of a lichenoid infiltrate. Again, hemosiderin, red blood cell extravasation. Lichen sclerosis, this very classic homogenized dermis that almost looks edematous, but very smooth. You can have a more prominent lichenoid tissue reaction, and in fact, you can sometimes have so many lymphocytes here, it can look like mycosis fungoides. But here you can see evidence of a lichenoid tissue reaction here, and usually lichen sclerosis on its own will be diagnostic. If you need to look at the clinical, there are these porcelain white sort of patches that can be seen. Here's your more classic example of a textbook lichen sclerosis, this band of homogenized sclerosis, and the lymphocytic infiltrate sort of beneath it. The interface change might be a little bit hard to see. You can see here evidence of an older interface reaction. Annular lichenoid dermatitis of youth is the one I mentioned where you have lichenoid tissue reaction affecting the tips of the rete. Clinically, their patients are young adults, usually kids, but can be seen in young adults, these annular lesions on the hip girdle, the shoulder girdle. And in contrast to lichen planus, it really involves just the sort of single rete, not the entire area of the dermis. Again, it almost looks like whatever shape that is, but rhomboid shape, claw shaped at the base with this nice annular lesion. Some people think it is difficult to differentiate this from mycosis fungoides because of the annular nature on the girdle area, but they are usually kids, and the lymphocytes don't have atypia, and it's polyclonal. Lichen striatus, band-like clinical lesion that's in a blastoid distribution, sometimes usually unilateral, going up the arm or the foot, usually in kids. It can overlap with mycosis fungoides sometimes, but this is the one that is going to involve the Eccrine coils at the bottom. Again, here, a little bit of an interface reaction, but eccrine coils are always involved. I mentioned that it's seen in kids, but in this particular case, it was an adult that had it after hepatitis B vaccination, which was sort of a new fact to me. I hadn't really heard of this before. It almost looks like linear lichen planus to me a little bit. Everybody knows this, herpes zoster, you've got the obvious blister and the vacuolar and the viral cytopathic changes. Here's an example of a lichenoid tissue reaction, but if you look closely, these cells have that same viral cytopathic change that you can see in zoster. So you can have a lichenoid tissue reaction with zoster. I showed you this one earlier, but the clinical pathologic correlation is going to be key. This might be my last one. Vitiligo can have an inflammatory phase in which you're going to have an interface reaction. If you look closely, you might see them around a melanocyte, but that's going to be rare. Usually, you just have, loss of pigment and maybe some pigment dropout. But here, there's actually a mild interface reaction. But you can see here there's loss of pigment with Fontana. Almost all the epidermal pigment's gone. Here's a little bit that's left. And then almost no melanocytes by SOX10. So that's usually clinical diagnosis. Sometimes it'll be difficult to differentiate this from mycosis fungoides when it gets very lymphocytic. But you look closely, the cells are not atypical. And again, you have a little bit of a vacuolar interface reaction here with the melanocyte. So that's it for what I have in terms of like lecture. I have more, but I think now, how do you want me to do this? Can you hear me?
Oh, yeah, yeah.
So what I have now is this could just be summary, and this is everything I've said. Why don't I just leave this for them to look at? Since it's being videoed, or I can keep going. This is going to take about 5 minutes.
Oh, of course, please.
I say 5, maybe a little longer, but we'll see.
It's all right.
Okay, so we're just going to just sort of summarize sort of what we see. So the way I did it this lecture, instead of saying, here's lupus, this is what you see, here's LP, this is what you see, we sort of took it in a way that you would, do it as you're looking at the skin biopsy. So you start at the top, look at the epidermal changes, blah, blah, blah. So we'll just summarize. So lichen planus, again, this is so much for repetition. You guys are probably going to, know this all by heart now, but sawtooth reedy, orthohyperkeratosis, reedy effacement. Sometimes you can have hyperplasia, and sometimes it can be atrophic. Lichenoid drug, that epidermis is going to sometimes show a mixture of spongiosis and interface reaction. It's also going to have the perivascular part that'll help differentiate from lichen planus. The necrotic keratinocytes sometimes will be a little higher than lichen planus, but that's not an absolute. And the presence of parakeratosis will put you more in the lichenoid drug. Fixed drug eruption and EM, remember you can see blisters in addition to a lot of necrotic keratinocytes. You might have eosinophils or newts at the junction and in the dermis. And then if you have basket weave stratum cornea with some parakeratosis, that is going to be sort of more fixed drug, although it can also have overlap with EM. Lupus, a lot of times, is going to be atrophic, except for in the hyperplastic variant. But you don't really have a lot of acanthosis with lupus. So if you have a lot of acanthosis plus some interface change or mild vacuolar change, and they're wondering about lupus versus eczema, lupus really doesn't get, acanthotic like eczema does. Looking at plugging is going to help. Looking at the thickened basement membrane zone will also help, as will the presence of mucin in the dermis. Pityriasis lichenoides, this can have a little bit of hyperplasia. It doesn't tend to be very hyperplastic, can be a little bit atrophic, but usually the epidermis has a little bit of reedy hyperplasia, but doesn't get real thick. This is the one where you have the parakeratosis that mixed with serum and red blood cells. A lot of times there's basically stratum corneum at the periphery. Sometimes you can see spongiosis and necrosis here, but pityriasis lichenoides, well, not sometimes, especially in the acute version, you can see a lot of spongiosis and necrosis. The Pleva or Pleva version or Mucha-Haberman version. But that you have the clinical pathologic correlation. Syphilis can be as I showed you, hyperplastic, I didn't really point out the fact that it's going to be one that's going to have a combination of psoriasiform acanthosis plus lichenoid. So when you see psoriasiform reedy plus lichenoid infiltrate, and people like to talk about the reedy being sort of skinny in syphilis, but that combination plus perivascular, you have to think of syphilis. And the thing I didn't show you, this is sort of something that for me is a big clue, is the presence of neutrophilic spongiosis. This was an interface talk, so I didn't really mention this, but I want to just mention it here. So trickling of neutrophils into the epithelium to me is also a clue for syphilis. Lichenoid keratosis can have all sorts of different ways it presents. And if it's a solitary lesion, usually under maybe 2 centimeters, then it's usually going to be lichenoid keratosis, but you always have to wonder about regressed melanoma in larger lesions. Annular lichenoid dermatitis of youth is the flattened, squared off reedy. Pigment purpura, epidermis is going to have minimal alteration, usually some gentle vacuolar change, maybe some lymphocyte exocytosis in the bottom part of the epidermis. And mycosis fungoides can have a variable epidermal silhouette, sometimes a little bit psoriasiform. This also has these skinny reedy, and sometimes can have atrophy adjacent to reedy. And then the secondary changes of the lichenoid tissue reaction are rare, but can occur, as I mentioned, and you really on mycosis fungoides have to look for atypia and also use clinical pathologic correlation and immunohistochemical stains. Looking at the dermis, marked pigment and incontinence is classic for LP. Sometimes you can have sort of the edematous fibrovascular expansion or that sort of regressive change beneath the epidermis with the chronic presentations, especially when you have some atrophy there. Lichenoid drug, edema, red blood cells, eosinophils, I didn't include there. LE, I told you sometimes red blood cells are sort of a common feature, not really talked about that much. Sometimes you can also have some neutrophils, mucin, and with chronicity, you can have some fibrosis. Pityriasis lichenoides, red blood cells, and remember, no EOs with pityriasis lichenoides. PPD, red blood cells, and hemosiderin, and syphilis, plasma cells, and plump endothelial cells. So these are some of the dermal changes you need to look for. With mycosis fungoides, the fibroplasia is a little different. It's almost like fettuccine change, is thickened collagen bundles, sort of parallel to the epidermis, not vertically oriented like you see in lichen planus. There's a classic sclerosis that you see in lichen sclerosis erythrophicus, but early on it might be subtle, and there have been some cases reported that don't have the typical sclerotic change. So that one, again, you need ClinPath correlation. Radiation dermatitis in the subacute variant that I showed you, you might see some sclerosis, but in general, you want to see in the chronic variant is where you see sclerosis with plump fibroblasts. And I didn't really go through the chronic variant, but that same subacute change that I showed you with the subacute radiation dermatitis can go on to become chronic. And at that point, you'll have more sclerosis and some of those sort of bizarre appearing fibroblasts. Fixed drug eruption, melanophages, as I mentioned. And the composition of the infiltrate, as I mentioned, usually in lichen planus, there are no eosinophils, but sometimes you can see them, especially on the leg with the hypertrophic variant. And sometimes you can also see plasma cells there. With lichenoid drug, eosinophils, sometimes plasma cells can be seen in that. Sometimes you can have a granulomatous component to it. As I mentioned with lupus, neutrophils can also be seen. There also is sort of a sweets-like lupus, but that's different than the type of lupus that we see with the lymphocytic infiltrate. The CD123, remember that is a helpful stain you can do to diagnose lupus. Fixed drug eruption, as I mentioned, has a lot of eosinophils in contrast to erythema multiforme. And you can have neutrophils. It can be neutrophil rich in fixed drug eruption, especially if it's an early lesion. Eosinophils are not seen in pityriasis lichenoides. So if you start seeing a lot of them, or even any, supposedly. You have to think of something other than pityriasis lichenoides. I didn't mention this before, but sometimes you can see CD30 staining in lesions of pityriasis lichenoides, but those should only be staining the small lymphocytes, not the big type of atypical cells you see with lymphomatous papulosis, which is classically positive for CD30. And with lymphomatous papulosis, you have that interface wedge-shaped lichenoid reaction, but you have atypical cells there. And with syphilis, the infiltrate is going to be rich in histiocytes and usually plasma cells, but they might be absent. Hemosiderin in pigmented purpura. In mycosis fungoides, again, you look for the cerebriform cells in the epidermis, but sometimes you can see them in the dermis. And in the halo reaction, you may not see the melanocytes. A lot of times, if you have a halo reaction and you think it might be a melanocyte proliferation, by all means, get a melanocyte marker like SOX10 or MART. And then the clinical features, we've gone over most of these. I don't know if I have to really repeat a lot of these. For lupus, in addition to the clinical lesions I showed you, they tend to have be in younger patients. If you have patients who are older all of a sudden getting lupus, you have to think about a drug-related lupus. And for lupus, a lot of times I don't have people get an ANA just random, because then you're stuck with a positive ANA that you don't know what to do with. But you really try to put all the features together and then, add an ANA to help, sort of supplement it all. But Rowe and Law, I think, can be very, very helpful if it's positive. Remember the lichenoid drug reaction, it might take a while to have its onset, even though it can happen within a week, and it's frequently due to the PD-1 and PDL inhibitors. And I think a lot of us have patients or have access to situations where that has been the case. But remember, it doesn't necessarily have to be stopped. They can get treated through that, at least as far as I know. Fixed drug, what I'll just remind you, in addition to being recurrent, it doesn't always have to happen. Every time you take the medicine, there'll be like a delay sometimes in how your body will react to it. So it can be random. So it's not like you can try it, and if it doesn't work, then it's not fixed drug. And also, it's not just like medicines. It can be suppositories, or some foods can have been implicated. Remember subacute radiation dermatitis, they didn't have radiation at the site. They had fluoroscopy that just sort of went through the body and sort of hit the back. That's my simple way of saying it. I'm sure there's some more sophisticated way to tell you that. If you're going to make a diagnosis of pityriasis lichenoides, these lesions are going to clear spontaneously. Sometimes the condition will not clear, so you say, oh no, it's not going away, but they have to really take note of the individual lesion, and sometimes it can take weeks, so it might be helpful to get photos and then check photos again later. And then remember, syphilis, check palms and soles, but really anything goes with syphilis, and of course at any age. Lichen striatus, remember, in adults are rare causes due to hepatitis B vaccine, but it's usually in kids. We already talked about lichenoid keratosis. Lichenoid keratosis, if you're going to make the diagnosis, it should, in my opinion, be on areas that have had chronic sun exposure, because it's supposed to be really a reaction to a solar lentigo. So usually if we see it, it's in the chest, is a common place, the arms, sometimes the legs. Sometimes the face. People didn't think it used to be on the face, but I've definitely seen it on the face. Annular lichenoid dermatitis, again, usually kids. It can be in some young adults. Pigmented purpura, these cayenne pepper-like patches on the lower legs. I showed you those brawny lesions. If it's generalized, you should consider mycosis fungoides or a drug. Mycosis fungoides, clinical features are double-covered sites of these lesions, recalcitrant to treatment. When you stop the medicine, the same lesion comes back. And then lichen sclerosis, the porcelain white lesions, which can involve the genitalia, but also the body and the extremities. And that is all. I went really long today. Sorry. Hope you guys have a nice day. So wait, hang on.
Thank you so much. Thank you, Dr. Junkins Hopkins, for this very comprehensive overview of both lichenoid and vacuolar interface dermatitis. covering all the entities and how to approach them. So there are a few questions I had seen online, and one question is from one of the trainees at Geisinger's Lipping. So the question is, first of all, he wants to thank you for the lecture, and then he has this question for you: that what are the VVZ staining patterns between regressing melanoma and lichen planus pigmentosus?
Thank you, Li Ping, for the question and the compliment. Lichen planus pigmentosis, it's hard to say. Not a lot of them are done, and in fact, I've seen situations where that has accidentally been called regress melanoma. But ideally, you would have melanocytes that would still be there. I can't say from the literature if that's absolute, and you would have melanocytes that are not, if they're there, they are not positive for PRAME. And the elastic tissue pattern should be more of a just that loose transition between loss of elastic tissue and the intact elastic fibers, as opposed to melanoma, which will have pushed down elastic fibers. But if you have melanocytes, they will be junctional and uniform in their presentation. You can have them balling up and make pseudonests. But with regression, really with melanoma regression, the melanocytes are gone. So to me, I can't say that that's 100%, but in my experience, that's been helpful. So I hope that answers the question. You can find me later, Li Ping.
Thank you. So there are a few more questions. I will read them for you.
Okay.
One question is, how do you approach cases where the interface dermatitis is subtle or overlaps with other inflammatory patterns?
So if the interface reaction is subtle, well, if I'm not sure, sometimes it's just very fuzzy, and it'll just, at low power, it'll catch my attention because the reedy pattern will be gone. And so I'll look and try to sort of, if I can, I'll try to find at least one remnant of a dyskeratotic keratinocyte. I might get some levels. If it's subtle, I just keep looking to see if there's another area of the epidermis where I could find some something to confirm it. A lot of times it'll be like a very subtle dyskeratotic keratinocyte. But other than just using my eyes and looking and trying to convince myself, okay, this basal layer is present here, it's just a spinous layer, I don't see any basal layer, and it's a little ratty or smudgy. I just have to sort of work my way through the epidermis. And then, what was the second part of the question? Overlap with other
inflammatory patterns.
I'm not exactly sure how to answer that, except for to so if I have an interface dermatitis, like, how do I differentiate it from other inflammatory patterns?
Maybe that's too broad, right?
Well, it's sort of the lecture I gave. So I would do things like, I'll check to see, so I basically I have a slide, I see an interface reaction. So in my head, if it's really band-like, I go through the list of things. Well, maybe it's lichen planus or lichenoid drug eruption, less likely to be lupus, but that'll be a little bit in the differential. So I first see the epidermis, I see that it's either has some damage to the basal layer or disruption, lymphocytes are there. Then I sort of go through my routine of, okay, is it around the vessels? Are the eosinophils? Is there is there parakeratosis? Are there red blood cells? Is there atypia? So my approach is sort of how I've laid it out here to help differentiate other conditions. I don't know if that answers the question. Is that?
I hope so. There are a few more questions. There is one question I just saw is that, can we consider syphilis with solitary lesion and pustulosis?
I have to say yes for any syphilis question. Um, with pustulosis and a solitary lesion, I think it'd be less likely, but there have been cases of lesions, and it's a little maybe not how they're thinking of their question, but I've seen solitary lesions removed from a perianal area with neutrophilic spongiosis. I can't remember if it had a true clinical pustule, and it was a solitary lesion in terms of how it was submitted. So I'd have to say potentially yes, but like a true pustular, like a halogenoderma type pustule, I don't know that that would be common, but I think, if there's any question, I just do an immunostain for spirochetes. And that can't, if you have an eruption in some patients, um, they might have a negative RPR. So you can't always rely on the clinician checking RPR. So if you have a question at all for syphilis, I think it's so easy to do the stain. I would do the stain.
Thank you. The next question is there a threshold for the diagnosis of non-specific chronic dermatitis?
I don't think I've ever given that diagnosis. A lot of people do. Chronic dermatitis. So the question is there a threshold for using the diagnosis of chronic dermatitis? Can you say the question again?
Yeah, so the question is there any threshold for the diagnosis of non-specific chronic dermatitis?
I guess I tend to try really hard to get a diagnosis. So I I probably I won't use the phrase chronic dermatitis because I don't know what that means to the clinician. Because does dermatitis mean an inflammatory condition, or does it mean eczema, like eczema dermatitis? Um, so I will personally, I don't tend to use that phraseology. If I have, I can't remember, but I will try to, as much as I can, get some clinical information, either photos if possible, and the findings. I'll do my best to try to put it in some categories. So if it's so if by chronic dermatitis you mean sort of an eczematous process, um, I'll look for the specific histopathologic features. So if I see spongiosis, or if I see, like, if it's more psoriasiform, you know, I could sometimes psoriasiform dermatitis is sort of like saying chronic dermatitis, but like if I see a sort of a psoriasiform epidermis, I'll look for any evidence of lichen simplex chronicus, and a lot of times that's going to be there. And I will then imply that it could be chronic, like it could be eczema with lichen simplex chronicus. So I think if there was a chronic dermatitis diagnosis close to it, it would be more of a psoriasiform epidermis with LSC. And to me, taking it 3 steps, away, that's probably an eczematous lesion, which has had a lot of scratching and rubbing. The spongiotic part is almost gone, but now it's a chronic dermatitis. So that's where I might sort of head towards that direction of chronic non-specific dermatitis. As far as the perivascular part goes and the interface, or the just say if you weren't talking about eczema, because I never know what people mean when they say chronic dermatitis. But for the let's say you just have a non-specific vascular, some epidermal change, maybe interface, maybe some sponge, maybe some perivascular. I try to focus on where I think the problem might be starting. So if I feel like there's more perivascular inflammation than there is epidermal change, I might focus on that being the problem. If it's a combination, like some epidermal change, some perivascular change, if there's some interface, I might try to go towards like Lichenoid drug, maybe. Again, I'm so relying on clinical, if it's got some non-specific perivascular stuff, a little bit of epidermal, alteration, little subtle spongiosis, I might go more towards a pityriasis-like, pityriaciform drug, pityriasis lichenoides. If it's more epidermal and less dermal, I would try to focus on either it being spongiotic, eczema type, or an interface. There are lichen planus tends to be, it usually declares itself histologically. Usually there's some element of wiping away of the reedy. So that's usually the interface reactions aren't in my classification of, chronic, non-specific chronic dermatitis. But I'm not sure if I answered the question. I said I rambled, but if somebody asks a question that and they need more clarification, please, feel free to put it in the chat.
Right. No, thank you, Dr. Junkins, Hopkins. So there is another question. When the differential diagnosis includes mycosis fungoides, what is the optimal way to use B and T cell rearrangement studies?
So, so you have a case where you have a lichenoid dermatitis, and they've submitted it as, usually what happens is they might submit it as lichen as mycosis fungoides, but you're seeing a lichenoid dermatitis, and that's where maybe it could be MF. It's rare that I see a lichenoid dermatitis and say, oh, this might be MF, unless the cells are, quite striking. But usually it's submitted as MF or sometimes psoriasis or, chronic eczema or something that tells me, it's more of a scaly patch plaque sort of thing, and I'd be less inclined to be calling it lichen planus. So in that situation, so I would already be a little bit suspicious. I wouldn't go straight to PCR and the T cell, gene rearrangement studies. I would do immunostains first to see if I can see, loss of CD5 or CD7 expression, higher amount of CD4 in the epidermis versus CD8. Sometimes there can be a mixture. It can be hard because you've got some reactive cells there too. And if there were, and I'm really a stickler on looking for cytologic atypia. So if I'm starting to see a lot of cerebriform lymphocytes in the epidermis and the dermis, plus areas in which the epidermis has been altered in a way other than the lichenoid tissue reaction, like some like skinny reedy pattern, or maybe some collections of Patria microabscesses like I showed you in the picture, then I would pursue PCR. I don't always pursue it if I don't think that it's there. If I don't think at all that it could be mycosis fungoides, I probably wouldn't submit it for PCR on the first biopsy I got, because if you have a positive clone and you can't call it histologically, then I'm concerned it might be a drug. So that's sort of my rule 1 or 2 or whatever. And then, so if I had a biopsy that really wasn't great for MF, I would tell them, especially if they wondered it, tell them that I, considered it, especially given the clinical presentation, but it doesn't have enough blah, 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 not enough cytologic atypia, not enough immunophenotypic atypia, and the clinical lesions were, suspicious. At that point, I might tell them to take another biopsy and then send that one to me. And then that one might have more atypia. And then I'll take both of the biopsies and I'll send them for T cell gene rearrangement for beta and gamma. And then I won't do B cell. And then if you have a clone that's the same on both samples, then that is supposed to be much more specific. It's not hardcore specific, but much more specific for mycosis fungoides than just a random clonality study. So sort of point number 2 or 3, forgot how many points I've made. Take 2. So 2 samples if you want to help confirm it. If they clinically really look like mycosis fungoides and it looks like MF, but there happens to be lichenoid tissue reaction, interface dermatitis, whatever, also there, but otherwise it's MF, I probably would just say it's mycosis fungoides with lichenoid, lichenoid variant or something. But to be honest, I think in that situation, it's better to get clonality to help support it. If you know, especially if you have a lot of secondary changes. And always make sure there's not a drug involved. So a drug can sometimes also have clonality. And so that's going to be important.
I think,
Can I answer that?
yeah, no, I think thank you so much again, Dr. Junkins Hopkins. I think one last question that I saw is this one, like, do you have any specific advice for general pathologists, or like, any specific advice that you want to give that in the pathology report that should include in diagnosing lichenoid or interface dermatitis?
So something important to include in the report.
Yeah.
I think probably the most important thing to include is, and it sounds not even cliche, it just, we say it all the time, but it's true, is to tell them that the findings will require a correlation with how the patient presents. I think that's probably the most important thing to tell them. I think if there's a question of syphilis, well, no, I think if there's a question of syphilis, you're going to check for it. I was going to say if you are hesitant to check, you could always, suggest it in the note. Sometimes I use the word Lues, Lues, because patients don't know that as well as they know the word syphilis. But I'll say, if there's concern for Luetic disease or Lues, to check for serology. But I think probably the most important is to include clinical information. Sometimes I direct them for what I think they might do. Sometimes I'll say it might be helpful to check Roe and Law, or sometimes it'll be helpful, to check something. But again, the most important thing for these is to correlate with the clinical.
Thank you. Thank you again, Dr. Jonkins Hopkins, for this excellent talk, and we really appreciate it. And thanks for all your time and sharing your experience and knowledge. And I'm sure the viewers are very much appreciative. And you'd be happy to hear that we had a lot of viewers, around 100 or so, who joined on Facebook and YouTube from different countries, including Saudi Arabia, Pakistan, India, Philippines, Zambia, Kenya, Zimbabwe. And of course, as you saw that your residents from Geisinger also joined. So, I mean, thank you again, Dr. Junkins Hopkins, for this excellent talk. Hope we can have you in future as well. And I also want to thank Dr. Hades Kapsky and Dr. David Casarino for organizing this dermatopathology lecture series. We really appreciate it. And for the viewers, so please follow our platform on different social media platforms, including Facebook, YouTube, Instagram, and X, so that you can stay updated with all the upcoming lectures. And our next lecture is actually on Tuesday. So that is on November 19th, and we will switch to an ENT lecture, and we have Dr. James Lewis from Mayo Clinic, Arizona. He's going to talk about blue cell tumors of the sinonasal tract, and it's the same time at 9 a.m. Pacific time and 12 p.m. Eastern time zone. So hope to see you all at that time. Thank you again for joining us today, Dr. Jonkins Hopkins. Thanks a lot.
Thank you.